Welcome to the latest edition in our series, Leadership Lessons in Troubled Times. These free online fireside chats are brought to you by the Schulich Executive Education Centre, or SEEC. My name is Robert Lin. I am Associate Director of SEEC and moderator of today's session, Leader Frontline Workers in a Hospital Healthcare Crisis. Our guest is Taggar, Executive Vice President, Chief Nursing and Health Professionals Executive at the Sunnybrook Health Sciences Centre. Rue will be interviewed by Alan Middleton, SEEC's Executive Director. During this session, if you have any questions, please feel free to use the chat function at the bottom of your screen. We will try to ask as many of the questions as time permits. We will also be video recording this session for those who are unable to attend the live session. Now, let's get started. Alan, over to you.
Thank you very much, Robert. It's delightful to be here. And boy, are you ever in for a treat, because my interview today is not only incredibly successful and important person in the field of healthcare leadership, but is charming and absolutely delightful. And you'll get a chance to meet her a little bit. Rue, thank you so much for joining us today.
Thanks, Alan.
Now, I know that all you've been doing in the healthcare area is sitting back and let everybody else handle it as we go forward. But I have to start with the obvious question. How are things at the moment, both within the hospital and how you're seeing it as we evolve through this crisis?
Well, first of all, I just want to say thanks to Alan and the university for having me here today. It's a pleasure to talk about this experience. My views are really representative of what I've seen and watched as a leader as we've gone through the pandemic response to date. And I also want to just start by saying I can't tell you how inspired I've been by what people have done around me at the hospital in terms of being responsive to the needs that have been thrown upon us. So I'll talk a little bit about sort of our initial response when COVID first hit, and then sort of what our response is right now, and they are quite distinctive. So when COVID first hit us as a society and particularly at hospitals, there were really three areas that we focused on at Sunnybrook. One was related to capacity. So we realized very quickly that we need to create capacity for a potential significant influx of COVID patients. We were watching what was happening around the world, particularly in Italy and in Iran. And we were basically assuming that the same scenario may happen here at Sunnybrook and within Toronto and within the province. So we were sort of doing worst case scenario planning, and the scenario planning actually were threefold. One was, what do we need to do quickly to create bed capacity, to create beds that would be available for COVID patients when we have to admit them? And it was ICU beds as well as inpatient beds. So that was one area of focus. And the way in which we quickly responded to that was we actually stopped doing surgeries and procedures within a matter of a week and a half. And we basically halted all of that activity very, very quickly. The other thing that we did was then we started to think about, okay, where are we going to put the COVID patients? And how are we going to care for those patients? Not really knowing a lot around what kind of care needs they would have. So we knew we needed to create an ICU unit and an inpatient unit. And so what we did was we started to think about what's the location and what kind of staffing, what kind of team do we need to build to best meet the needs of those patients. So that was one area. And we basically, as I said, within a very short period of time, reduced our hospital capacity from, on average, it was 107%. To 115%, down to 50%. And then the other area that we focused on was supplies and equipment. So we realized relatively soon within this process that our PPE supply, and what I mean by that are our mask supply, our gown supply, all of the equipment that the staff wear to protect themselves and patients related to the transmission of these types of diseases. Our supplies were unstable, our supply sources. So we very quickly got a handle on how are we going to monitor our supply source closely and on a day-by-day basis, and what do we need to do to conserve our supplies. So that was another area of focus. We also started to take stock of the number of ventilators we had, and then we started to think about, okay, if we get X number of additional patients, where are we going to house them, and what kind of additional equipment do we need? And we did that within the context of all of the Toronto hospitals, and we did it in coordination with them. And then finally, and this was probably I would say probably one of our most priority areas of focus, were our people. So we focused on, okay, so what are the teams that we need to look after COVID patients? What kind of skill set, what kind of staff do we need? And we needed to enhance those teams. So we created new roles like safety officers. So people that were just designated to watch our staff put on their PPE before they went into a room with a COVID patient, and to take off their PPE safely when they came out of the room. So we created enhanced teams, and we created teams of critical care staff as well as other staff to help support the types of needs the staff would have in caring for these patients, as well as the patient needs. The other thing we started to do very quickly was we started to think about wellness in a more concentrated way. So appreciating that this was going to be drawing upon our staff emotionally, mentally, physically, what else do we need to do to support the wellness of our staff? So I would say there were 3 areas of focus: capacity, supplies and equipment, and people. So that was in the beginning. It was highly intense. We were making decisions hourly at times around how we were going to best approach this and how we were going to do it, and where are we going to shift staff, and which areas do we need to really bring down and reduce in terms of their activity. But now let's fast forward to today.
Can I just before you move on, one of the things that was so impressive about how you responded, and I'm hearing this as part of the leadership lessons from other people, is breaking down those silos, listening to people with skills that you needed from across the organization. You talked about supply chain, you talked about that. How was that done? How did you get that communication going across those silos so well?
Yeah, so I mean, we had a good governance structure. So hospitals always have emergency preparedness plans,
right?
And it's called incident management systems. So we drew upon our, it's called an IMS structure, and we engaged that structure very quickly. And I think all hospitals did that. Excellent. So basically we had a structure of executives that were leading sort of the higher level decision-making related to the response. The executives were also very much connected with other hospitals, and we were sitting at regional tables, bringing in that information. We were helping to advise on policies across all hospitals and setting those policies. And then internally, we had an executive table that were sort of driving operations. So we would give an operations group sort of, here's what we've decided, now operationalize that. We had a PPE group. They were feeding us information, and we were also guiding them. So we had a number of different groups that had different functions.
It's excellent. I want you to go on for the future, but just a note for our audience. There are some business organizations and other government organizations who do this, but let me tell you from our own risk management practices, not as well as the healthcare institutions. So you're very much a group for people to learn from for the future on how that works. So well done. But let's talk about the future.
Yeah, so right now I would say we're in a ready and steady state. So what we've done since that initial response is we put a lot of new practices and processes in place, not different from any other organization, quite frankly. So if you come to a hospital today, you're going to be screened at the door if you're a patient. And if you're a visitor, you may or may not be able to come in to the hospital. So we are still restricting the amount of people traffic coming into the hospital. Everybody has to wear a mask. Our operations are actually extended now. So for example, the amount of time it takes to clean between a surgery is much longer. So there's more enhanced cleaning practices. We only have a very, like we basically have one COVID patient in our hospital today. So the volumes of patients are very little right now. Having said that, the teams are ready and they remain ready, and we have designated areas where we would house incoming COVID patients. So that's the ready state that we're in.
Mm-hmm.
Staff have had the opportunity to practice and care for COVID patients, and we are potentially expecting another wave.
Mm-hmm.
And so we're continuing to balance the needs of our regular activity, which has been a bit of a back and forth balancing act. We've resumed surgeries, which we hadn't obviously initially, but now we have just about to 100% of what we ordinarily would be doing. So we're balancing sort of maintaining the regular activity that we need to maintain to meet the ongoing needs of the community at large, and being a trauma center and being available to the province for specialized care, as well as being ready for what may come our way in the future, near future potentially, related to addressing needs of incoming COVID patients.
Reflect back, some things surprised you, for both you personally, but also the people you work with going through this process, both positive and negative? I mean, you and I chatted earlier, and you guys must have been absolutely exhausted, physically and mentally during the initial period. How do you relieve that over time? So a little bit of reflection about your own life and your colleagues.
Yeah, I'll tell you what, I'll start with what surprised me, and I would say surprised and inspired me. So the things that surprised me were sources of inspiration to me, stories of inspiration. So to give you some examples, when we initially said, okay, this unit is going to be a COVID unit, let's approach this by asking staff with the right skill set to volunteer from across the hospital to work in those areas. And I said offline to my colleagues, I don't think we're going to get anybody. Well, it was surprising how many people volunteered to work on those units. And mostly we were able to populate the units with a team of staff that actually volunteered their time to work there. They wanted to be there. So I found that inspiring and motivating. And to your point around, how do you manage your exhaustion and fatigue, which I can talk a little bit more about that in a minute. But it did inspire me and motivate me and sort of help me with my feelings of exhaustion and fatigue, because I was like so inspired by the people and the staff I work with. Another example to give you is long-term care. So as you know, our long-term care partners were having lots of challenge, and some of the long-term care homes in our immediate catchment area at Sunnybrook were having some challenges. And so we deployed our teams to go out and help the long-term care homes. And we asked staff to volunteer their time to do that. And again, I didn't think we would get anybody. And when we sent out the first call for anybody who would like to go and volunteer their time to work in a long-term care home, which is in outbreak status, we had 60 people come forward and say they wanted to do that. So again, it was so inspiring. So in terms of managing my own personal exhaustion and fatigue, and I have had times where I have felt absolutely exhausted, fatigued, worried, and stressed out to the point where I want to throw up. And I've said that to my colleagues. I feel like I'm going to throw up right now because of the intensity of the issue. The way in which I was able to manage that, and you're not going to be surprised by this answer because I bet you anybody else would say the same thing, and it truly is true, is I felt like I was always in it with colleagues. Like I never felt I was alone in dealing with any of these issues. And so the way a team bands together in a crisis There's nothing like it. I saw it when I used to work in the emergency department as a nurse, and I experienced it again. So the leadership that happens and the team behaviors that happen in a crisis situation, there's nothing like that. And that gave me a lot of strength.
It's again the importance that people have mentioned previously, and I can't think of a better example than you're talking about, which is a shared value system in the culture. I mean, the great advantage you have in one way is you don't go into medicine at any level unless you've got some sense of caring about people. So a major strength to that positive culture. We're beginning to get some questions coming already, so I'm going to go to one. Does management, this is from Saichani, does management refer to people who come for healing as patients or clients? They are not the same and are treated differently. As patients or clients. How do you think about them as, I think what Sai's getting at in the question is a contrast with our more private sector orientation down south versus here. Do you see them as clients or patients?
I would say either or. I mean, I don't make a distinction between, it's all the same. I mean, we are a service industry and we're there to meet the needs of our patients or clients. I would say the values behind the relationships that we have with our patients or clients, whatever you call them, are the same. So I see us as a service industry, quite frankly.
Thank you.
Yeah.
Back to me. With your background and your current responsibility, you represent a group who, and I'm not putting doctors down or the administrators or anything else, but if there is a real front line, it's the nurses. And it always has been, you know, the probably the strongest relationships that you get in any healthcare are between the patient and the nurses. You've got people who are single mothers, single fathers, various states of marriage and relationship. How did you manage those pressures on your staff?
Yeah, so that's a great question. And you're right, there are lots of unique characteristics of this situation that I have never seen as a leader before. So one is what you've stated. This situation impacted our healthcare workers in a deep personal way. So to them, this was about working in a highly unpredictable environment where they had little sense of control, and where the implications to them were on a personal level. This was about, so what they were worried about, I mean, beyond, it's a given, they were worried about their patients and therefore their patients, but they also had this added element of concern around their own personal safety.
Absolutely.
Their families.
Yeah.
And that I've not seen the degree to which that issue manifested itself ever before as a leader. So there were some significant, unique challenges that the staff, I was sensitized to early related to what the staff were experiencing. Plus, add on to that, PPE. And there were times where the staff were very well aware that we did not have a secure source or a stable source of PPE. And obviously that worried them significantly. So how did we sort of work through this with staff? As a leader, there are a couple of different techniques that we as an institution used and that I used personally with the staff. So the first thing is sort of the approach of being genuine and transparent.
Yep.
So when I went out to the units, I would ask the staff, we would have real visceral conversations related to, I would say things like, tell me what worries you have today for yourself, for your patients, and for your team. Let's talk about those. Let's talk about things that we can control, and let's work through that. So I would break down the complexity of the issue by like bringing it down to, let's talk about today and what worries you right now. The other thing that I would say to staff often, and I think it resonated with many of them, was I never want you to worry alone. We always had conversations within the context of a team because I wanted to ensure that the staff staff felt, like I felt with my colleagues, that they had the support of their team in working through this issue, because quite frankly, I don't know how they can do it without that, because there's so many substantive issues. And then I would, in terms of communicating, it would be very factual. Here's what we know today. Here's our PPE supply source. We've got X number of weeks of supply today. That's not to say this will change tomorrow. This is what we're doing to better understand our source of supply. This is what we're doing to conserve our supply source. So I would really break it down and to be very factual in terms of here's what we know, and to be very honest with them. The other thing that we were doing at Sunnybrook, as other hospitals were doing, is the way in which we were communicating broadly. So we had daily, sometimes more than daily messages going out to the entire hospital around, here's the number of patients we have, here's the decisions that we made related to X, Y, and Z, here's what you need to do, here's what you need to be aware of today. So there was a lot of, our VP of Communications has been really awesome in leading the way as it relates to that, but the communication was crisp, clear, factual, and we got lots of really good feedback related to that. And then finally, sorry, I'll stop.
Go ahead.
I just well-being of staff. So we put other practices in place to help acknowledge and support how the staff might be feeling. So we had, for example, we created an additional enhanced program called the STEADY program. One of our psychiatrists led it. And basically she ran focus groups with staff where they could just come and talk about how they were feeling, address any concerns they had. We did surveys of staff. There were lots of supports that we started to put in place, really acknowledging that the staff needed some extra support in terms of their own well-being and having the ability to talk about how they were feeling.
Yeah. I'll build on a question we're getting from Philip D'Souza, and I'll read his question. We work closely with Rue and her team at Sunnybrook. They are so dedicated and are true leaders in the sector. So take the congratulations.
Thank you.
My question for Rue is, one thing emerging leaders can learn and put into action today in their leadership toolkit. And I want to build on what you were just saying, because that intensity of the communication is exhausting, financially, in personal terms, organization terms for the organization. So probably the level of it can't be sustained, but what can we take forward for the future? Because if all of a sudden we drop back and don't recognize what has been of value for this, then we won't reap what are some potential advantages. What would you say out of this for the learning for the future?
Yeah, so I'd say from a communication perspective, and then I'll speak more broadly. From a communication perspective, genuine, transparent communication goes a long way. Being visible and communicating the message goes a long way. So looking at people in the eye and talking to them about difficult topics goes a long way. So I think on the communication side, there's lots of different ways to do it, but I really noticed that people appreciated that genuine, sort of factual, transparent. And more broadly, though, it's been very interesting to see sort of how the system is transforming. And it is transforming as a result. It's been made to transform. So one of the things, and this won't be surprising to you, is around virtual care. So most of our ambulatory clinics, our outpatient clinics, were functioning still. We were still providing care, but we were doing it virtually. We were doing it using digital means. And I think the wave of the future is to continue to go that way. It's more convenient for patients, and it decreases the risk, given the current COVID environment, of having people come to an institution to be seen on site. There are obviously some circumstances where patients do need to continue to be seen in person, but people are realizing, like the healthcare system is realizing that virtual care isn't as challenging. It doesn't pose as many barriers as what people might have thought about initially. So
well, especially now, as people in lots of other parts of their lives are getting used to this kind of communication.
like this Zoom meeting, right?
Exactly.
Who would have thought, right?
Exactly.
So virtual care, digital care, I think is going to be the wave of the future, and it needs to be, and it's best. It's good for a lot of reasons. The other thing that I've really noticed is around in hospitals is how we staff our teams. You know, in the past, we've traditionally, in critical care, for example, you have to be a critical care trained nurse. You have to have X number of education and this level of competence in order to work in that setting. Well, we knew that and it may happen coming up, we knew that we wouldn't have enough ICU nurses. So what we started to do is we started to build team-based teams. So we partner one critical care nurse with a nurse who doesn't have a critical care background, and they work together to care for a group of patients. So we were leveraging expertise in a team-based approach. So those are kind of new staffing models that we've never really used as much in the past. And now all hospitals are looking at doing that. And if we have another wave of COVID, that's what will happen. Now, these nurses who are working in those areas that are not traditional critical care nurses have some level of competence. So they are put in an environment that is not beyond their scope of practice, but they're teamed up and we put the appropriate supports in place. The other thing that I would say is a little different now is it caused us also to think about, for example, surgeries. So sometimes when you have a surgery, you know, you spend 1 to 2 days in the hospital after your surgery. We asked ourselves the question, do all of these patients need to be admitted? Or if we had them stay one night overnight in a day surgical kind of setting, then we could send them home immediately with maybe some additional supports in the home. So we started to look at delivering care in a different way. And that I think is transformative, and that I think is going to be very useful in the future.
And we've had some experience of this in various provinces of Canada, because I know, for instance, British Columbia was doing distant diagnosis to some of the Aboriginal groups, actually for quite a long time, because they couldn't afford to set up healthcare there. So it's bringing up some of the skills we were learning, but perhaps not applying properly.
I agree.
So I've got a tricky question here. So tell the doctors not to get upset. But for one of our questioners, sometimes doctors and consultants see themselves as elitists. How do they respond in an environment like this that requires such a shared culture?
Well, I would argue that at Sunnybrook and in just about all hospitals, we do work in teams. That kind of environment where there's, you know, differentiations, it doesn't happen anymore in the healthcare system. So we've got cultures in our hospitals where people are working much more collaboratively within the context of a team than they ever have been. And this was another example of where I saw teams, not individuals, not just individuals, step up.
Yeah. The other thing you mentioned, and actually some of our healthcare people have mentioned this before, the sector communicated across the different groups quite well. You mentioned that there was sharing of hospital learning, that you were watching what was happening in Spain and Italy in the early days. We've heard from the head of one of the big pharmaceutical companies that he found that dealing with the healthcare operations like hospitals, but also with government and the drug companies, there was less bureaucracy going across and more of a willingness to cut unnecessary red tape. Can you talk about your experience with that one? Because, you know, we all know in periods of calm, the bureaucrats trying to get in, you get lots of things that look like they're there for good reasons, but they really are slowing the process. And that team that you've constantly emphasized must be outside the institution as well as in.
Yeah, the best example was long-term care, when we were helping all hospitals, were helping long-term care institutions. And quite frankly, in the past, we haven't really collaborated very closely with them. It could have been better. Let's just put it that way. Yeah. So we basically formed their team. We were the team with them to help address some immediate issues that they had. I've never seen collaboration like that ever in my career. And so you're right, the silos were broken down. Government basically said, we're in a crisis, they need help, and they need your expertise, hospitals. Please go and help them. And literally within a matter of a week, we basically sort of engaged, got in there, sent our staff, we sent PPE, we had staff getting in their cars, loading up their cars and trucks with PPE and sending it over to long-term care. We had our infectious prevention and control specialists go in, and we formed new teams, new levels of collaboration that we have never formed. And I have a greater appreciation of long-term care facilities now because of that as a leader. So that was one example. We also formed, I mean, we always had pretty good collaborative interfaces with community agencies, and we did that much more. So those kinds of silos, I would say, got broken down more so than ever before that I've seen. And you're right. So we were also trying to manufacture our own masks. Like we were trying to figure out how to. So we were interfacing with other manufacturers. We were interfacing with our own researchers and retooling our own equipment to see if we can make our own masks, which we're still doing. We're still looking at ways in which we can manufacture our own product. Not just us, lots of hospitals. So there was cross-sectorial everywhere in terms of the collaboration.
Yeah. So we're at an end. I'm about to palm back to Roger, but I'm getting so strong. Team, not just inside, but outside. Don't lose that as we move forward. Even if there's not a second wave and we go back to a new normal or whatever the next normal is going to be, we can learn so much for that. And then I'm going to add one more thing, which is outside the healthcare organizations, other organizations need to learn from you people, because I'm seeing a lot more good decision making than what a lot of the private sector and other parts of government could learn from. Roo, it's been an absolute pleasure having you here. I'm going to hand it back to Robert to do the close, but all I can say is to anybody, with the healthcare system represented by Sunnybrook, thank goodness we're in the right side of the border and in a good place. Robert.
Thanks very much, Alan. It's a pleasure being here. Thank you.
Thank you to everyone for attending today's session. Please feel free to join us at our next Fireside Chat session. That takes place on Tuesday, July 21st with Anita Swamy, the Vice President of Medavie Blue Cross. A special thanks to Roo for being here today. Have a great day, everyone. Stay safe, stay healthy. Thank you.
Thank you, Roo. Thank you, everyone.
Thank you.